Hi there. I'm a researcher at MIT. Just a question for you all, really, around data ownership. Data access obviously is very valuable for provider and for patients, but data ownership is slightly different. It also addresses and affects access. So if you have thoughts or comments around that.
Jump right in, whoever.
Yeah, one take on that. One of the things that didn't get mentioned in the introduction is I'm also involved with a startup in the space. We've made a philosophical decision. This is going to work, that the data has to belong to the person. That is a fundamental starting point principle for this sort of data. Providers trying to claim ownership of personal data, health data, that sort of stuff. Now that may run counter to what a whole variety of other people are doing. But for this data, more than any other data, must be owned, must be controlled, must be managed by the person.
I think that's right. I do think that society would need to come to grips with what it means to decide you don't want to share that data with your providers and others, because that may be, in fact, that you become more of a high cost to the system, and right now there's no consequence to that, but I completely agree. It's your data.
I think it's interesting because I'm going to come back to the underpants example, which is I absolutely agree with that philosophically. I also need my company to make money. And for it to make money, I have to have access to lots and lots and lots of people. Therefore, I go to customers who are aggregators. And when the customer says to me, oh, Alex, you're so cute. I love that idea. I love if patients could own their own data. But they're not going to. I do. And if you don't let me own it, you will not have access to my 5 million, 6 million, 8 million, 12 million members. And then guess what I say? Okay, you own their data. So longer term, I think we will empower individuals to rise up and say to their health plans or their PBMs or their pharmacies, I own my data. But until they do, it will be difficult for startups who are looking for access to people to be able to market to them and make a difference with them. It will be harder for them to stand that ground.
I think this is a sort of question about principle, and I'll buy that there are aggregators out there who are claiming ownership of the data. First of all, that's almost uniquely, when it comes to this sort of data, a North American phenomenon. Right? If you go almost anywhere else in the world, the way the regime is set up is that it is actually the consumer who both legally, factually, and economically owns the data, which is a sharp contrast. So we're in the last bastion where that is possible. Secondly, if you're trying to build a business over really, really long term, I'll buy where you're at. But candidly, at the end of the day, I don't want to give up my underpants. Right? I don't want other people claiming they can steal my underpants from me.
But that's you as an individual, and so you can call your health plan or your doctor and say, you have to give all these companies my data. This room full of entrepreneurs who are trying to get access to those individuals so that they can get paid and change their health. It's just, I agree with you, ELISA doesn't work internationally yet, so we live in the US. I'm sure many of you do too in terms of what you're selling. So I agree with you 100% philosophically. I'm just a whore for being able to actually get out and talk to large numbers of people. And right now, the reality of that is the individuals paying owns the data.
So we've had that as our privacy philosophy on our website for the last 2 years. It sounds like they're the same for the But it actually, if you have to hold that stance. So what's interesting about our data is even if you gave it to the institution, they wouldn't know what to do with it. We're talking about a million samples of data per user. Most even EMR and HRs aren't designed to process or capture the value for data and then just throw it in Dropbox and Excel files, and that's a security risk.
You actually just gave a good segue into my question. So given that the average primary care visit is like 9 to 12 minutes long, is there much thought as to what the provider can do with the data and wants to do with the data? And have you guys thought about any sort of barriers to acceptance with the actual providers into having this new influx of data and what it means to them and how it's going to inform their treatment decisions?
I got a big problem. On average, if you make people healthier, the incomes of primary care physicians will go down when things being equal. That's a big problem. It's the single biggest incentive mismatch we've got in the system at the moment. If I'm a primary care provider, I make my patients healthy, in North America, my income goes down.
I would also argue that while we in this room probably have a good relationship with our doctor and pay a lot of attention to our doctor, a lot of people don't. In fact, 50% of the US doesn't have a doctor, and the 50% of the US that does, 50% of them don't even know their doctor's names. So absolutely, when you're looking to do something, leverage the person who's got a strong relationship with their provider and start there because they're already more engaged. They're more likely to be a quantified self or all those things. But we have to start developing solutions that are not so heavily provider-centric, because real people, especially the generations that are coming up, just don't have that same hallowedness when it comes to their doctor.
And by the way, I'm a pragmatist about this, which is knowing people who work in regimes which move away from fee-for-service and those sorts of compensation mechanisms, there is no panacea. The systems who've been trying to do things on that basis, I think, made 2 or 3 iterations into designing those systems. They've dealt with the first and second order problems. So there's a lot of international experience to learn from in terms of, well, the first time you do it, you get it completely wrong because you design it in a way that doesn't deal with different populations and can be gained. As it happens, my brother-in-law is a primary care physician in an extraordinarily economically disadvantaged area of the UK. So when they first started this scheme, it was like they just got completely cake. Because from a statistical point of view, they were one of the outliers in the UK distribution. The bottom, it was in the bottom single percentile of the country. And then, okay, so when you compensate for that, so you've got to deal with how do you weight socioeconomic factors, and then they create a set of regimes. They go, well, actually, this is creating a bunch of reverse incentives. There's a systems and incentive problem. But by the way, the biggest current single barrier we have in our systems is primary care physicians are disincentivized to improve the health outcomes of their patients.
Just one last final point. I think the delivery model is fundamentally being disrupted itself too. So telemedicine is being reimbursed now. So CMS is finally getting their shit together and they're starting to understand that you can engage a patient. They don't need to be physically in front of you. I think beyond that, retail clinics, well, they started off as just a way to go buy CVS to drive more people buy magazines and crayons and all the other high margin items through the store. They're actually partnering with health systems now to run diabetes management programs. Because you're walking into CVS and Walgreens and Walmart all the time. And especially Walmart in certain areas of the country, the demographic that walks in there is actually highly prone to have diabetes. We have other clients too that are doing Ready Clinic down in Houston. They're inside grocery stores and actually prescribing bags of groceries to people. So I see devices like this going on the shelves there, and they have an engagement program and you can tie them in. So I agree that PCP is a broken model, but I think there's other avenues that this move can move through.
The 2 big bastions of hope in the US system for me, above all, are the VA, because in essence they're integrated, and they actually have a very long-run perspective of that. And actually very big companies who are in essence self-insuring their health scheme, because again, they have the right overall incentive in terms of how they manage the provision system. I may be creating Christmas of horror on my right, as I say those sorts of things.
No, just to answer the question, most primary care doctors, the question is answered with another question, which is, are they spending the 8 or 9 minutes on the right stuff? And we're so trained to think that it's okay to make decisions about your blood pressure based on 2 meetings taken in the office, twice a year. I guess what I would say is 2 things about that. 3 things. One is that software can help. So software can cull out all the meaningless stuff and put it aside and give you information rather than just raw data. In our experience, providers react positively to that. Secondly, it's almost never the doctor that's frontline on this sort of stuff. It's more likely a nurse, a pharmacist, someone who can spend more time managing a population, and that's that person's job. And thirdly, the payment model is changing, and it does matter. And here in this state, we are now at risk with all of our providers. I said that earlier. Our docs are thinking very differently about this stuff. So I guess that change in payment model brings a lot of work.
The only thing I would add to this is something that Charlie Baker actually told me once, which was 85% of the system is exactly how you described it, and 15% of it is changing. Now, whether they're changing the right direction and how many nutritions we don't know that yet. But 15% of, I don't know, $50 billion market is still a market.
But to my point, I think to Joe's, it is changing. My point about the technologies are converging, but the economics are changing rapidly. So there is hope. There's a quote we have on some of our business health, and the back of it is, the future is already here, it's just not yet evenly distributed. And that's actually our problem. We've got to distribute the future a lot more evenly.
We have a question.
No vote Republican, for Christ's sake. Really, I'm serious. We're going to change the future around incentives. Yeah, what do you do?
Go ahead.
I'm Bob Rudin from the RAND Corporation. I have a question about something we haven't talked about so far, and that's healthcare costs. The cost of care in the U.S. is widely well known to be higher than any other industrialized country per person, but the outcomes are no better. The quantified self movement with all these new technologies has the potential to increase costs, especially if they're expensive. Even if the prices go down, these new technologies are going to cost something. So I want to get your opinions on how can the quantified self movement reduce the cost of healthcare?
I'll start, which is the good news. Technology, relatively speaking, is dirt bloody cheap compared to even any single surgical intervention or a week of any significant chronic condition. The technology doesn't cost worth shit.
Anmol, I think you want to.
Well, that's a great question, and to perhaps paraphrase a little bit what my colleague said, the way you have to think about it is what, frankly, what costs are you preventing? And that's really how we tend to run our ROI models. And so I'll go back to a program I talked about, which was heart failure telemonitoring, and it ran by quickly, but the metric was readmissions. So each time a heart failure patient doesn't go in the hospital, someone, and lately that's us because again we're at risk, someone saves $12,000 to $14,000. So the cost of keeping them healthy in their home is trivial compared to that. And that's how we run our ROI models on this type of stuff.
Yeah, and I think there's two cost factors there. So one is the cost per event, and the other is transparency costs, and they're slightly different issues. I mean, just to add to that, new patients on our system are costing hundreds of thousands of dollars per year. And you save 10%, you reduce a couple of events that pays for the system in the entire hospital.
I think one of the most interesting things for me personally, having been in this space forever, is how frequently we have conversations about cost that avoid the massive blue elephant in the corner, which is end of life. That's where the money, for the most part, is getting spent terribly on bad outcomes and bad quality and shorter lifespans and people not getting what they want. So I can't wait to have a lot of time and energy to focus on the cost of the quantified selfers. That's a great day for all of us. What I think we need to be brave enough to address, and this means talking about things that are uncomfortable for each of us, is how do we do end of life better? Because those are dollars that are spent terribly to literally no good end.
So I'm possibly a little bit different to a lot of the folks in this room. I don't work in healthcare. I'm actually in digital marketing and analytics. And one of the things that when we talk about this stuff that I just feel is inevitable is going to be the consumer marketing organizations that want to get in on this stuff, and the ASICs that want to advertise a new pair of shoes in the gym that wants to get you to sign up for a membership. So the privacy aspect has kind of the two players, the person and healthcare and their providers, but there's also this third one, and I'm curious what you guys think about that and how it's going to happen.
I think a stat of that because every 2 months we get approached by, or this is start now, we would get approached by a Groupon competitor who wanted our behavior data so they could sell their ads. And every time we sort of looked at them, and, you know. So I think for a company like us, at least in our context, it's really important to have a trusted relationship with the patient and provider. And that has to be reflected in things like our privacy policy and how we secure it in all different dimensions. And so there may be opportunities outside that we haven't discovered yet during the last couple of years. We've shied away from that.
What he said.
Yeah, the horse is out of the barn on this one. I mean, we really, to spend any time sort of wringing your hands over it whenever you go on the web now, your browsing experience is unique to you and it's peppered with stuff. It's based on the search you did 2 days ago. It's done. It's done. We just have to get used to it. And so this stuff will filter in. One of the dreams we have is that we can learn enough about you to, instead of having you push the buy button, have you push the get healthier button. But basically use the same tools. I think those tools are very powerful.
I think the other thing too I would say is, I think it's really funny if you think about the competition for the people in this room, it's food, tobacco, and beverage. And if you think about the way that they market their goods, however they do it, it's, smoking hot supermodels with bacon grease running down their arm. And we're like, here's a picture of a diseased kidney. Join our diabetes program. And it was funny because I just was at an event at Sam Cass, and if any of you don't know who Sam Cass is, he's really bright. He's also very good looking, wonderful to pay attention to on so many levels. And he said, he was talking about that what food has to learn to do is market, basic marketing. Pepsi is not saying, drink our soda pop, because when the sugar crystallizes on your tongue, it sends signals to your brain which release serotonin, and that's a good thing, right? They're like, Pepsi, right? And we're like, eat quinoa because it lowers your blood pressure. And so I think however we decide to deal with the privacy thing, we have to get desirable with what we're doing, or it doesn't matter what ads we're selling to anyone, they won't have an impact.
I agree when I drew that chart about, hey, we have all this data. The problem over here is actually the behavioral science. With the exception, I see at least two faces in the industry who I recognize as having really strong behavioral science background. Who here has an academic background in behavioral science? Okay, put your hands way up. Right? These are the important people in the room. These people is Udo, Dan, I see two or three other people. These are actually the important people in the room. That's the problem. Like those people again, so you can spot them if they're a neighbor.
So I see my friend Rodrigo, he wanted to jump in here.
Thank you, I'm Rodrigo, I'm in design. I actually think that, that question is really interesting. If I have all my genomic data right now and all my phenotypical data available right now, I'd probably not give it to my physician who happens to be partners, and I have great relations with them. I would give it to Target, I would give it to Newton Running, I would give it to Apple, I would give it to places where I get great experiences. Help me now have a better experience in that. Overall, we're amazingly lucky to be in a place where we have the care of our colleagues in some of the best places in the world. But for the most part, still, the experience of healthcare sucks. Unless we design that experience to be better, with some elements that Alex is mentioning, all the data in the world, I'm still waiting my results from a test I had at Brigham 8 weeks ago. So more data, I don't want them to have more data at this point, quite frankly. So unless we push really hard to improve the experience, I think we're stuck, and I think there's a lot to learn from other industries that have done that well.
Anyone want to jump in? Add to that?
Amen.
Question: why is user experience in healthcare so bad?
I think part of that is most people join the healthcare system for very, very noble reasons, right? They do it because they believe. They think health is incredibly important. They are mission-driven to change the health of individuals. The downside of that is they think that everyone else in the world is like that. And so they design systems and processes and marketing, collateral that starts from their view, which is actually diametrically opposed to the view of everyone else that we're trying to influence.
My cause is noble, why don't you just get it?
So my question is for Adam is kind of, we're collecting all this data, we do a lot of things with it. How do we take that data and how do we have, patients understand, what that data really means and how I can take actions from that data? Should that come from a doctor or should it come from, an app or something telling me that my blood sugar is low and I need to do something about it?
Both. Don't take my skepticism about incentives and payoffs to say that I don't think they're highly complementary. I think to solve this problem, it's going to take a mixture of bottom-up, self-motivated behaviors and behaviors which put physicians and nurse practitioners and actually experts, consultants in the loop when it's appropriate. But they're trying to solve it in sort of a single point ain't going to work. It's going to be hybrid systems because if you just try and solve it with people, it'll be too costly. If you just try and solve it with machines, we're a long way from able to do that. So this is going to be man and machine. So it's the two of them in combination as appropriate.
So the one thing I would add to that is
man or woman
is I think what we think the future is actually this is a really interesting combination, right? So part of when you look at insights or health tips or advice or marketing, at the end of the day, everything that's done today is static, right? And you mentioned this in your talk, and it's a big part of how we think of the future is you don't really want to send messages on a weekly basis or a monthly basis or send them a PHQ-9 or the one mood question survey. What you want to do is know this person's been sitting around 4 days. They haven't spoken very well. They're probably eating a pint of ice cream right now and are depressed about something. And that's when you want to send them the message or the health tip or the find a picture or whatever that is. And I think, or send them a person. Although I think there's a lot you can do automatically before you reach into the domain of sending them a person. Yeah, so I think that really is where the future lies.
In the back.
Thank you for taking my question. My name is Cindy Cronenshield. I work in the life science industry, but I also am a practicing clinician. I'm a licensed registered dietitian in private practice. We talk about data analytics and the amount of time I spend with patients. I spend more time with my patients than their actual physician does. And a lot of people come to me with help to manage weight, whether to gain weight, lose weight, help with medical nutrition therapy to address a certain health condition, or they just don't know what to do with food, but know that food is healthy for them. Their physician might spend maybe a couple of minutes helping them. I spend close to an hour, hour and a half sometimes. And I can be armed with all of the data and all of the tools. I use genetic testing. I use products from Pathway Genomics, from Interleukin. I have information that will help a patient make the change that they need to get healthy, to have a balanced life. And it's not just about food. It's about what they do for work. It's about the stress. It's about the triggers in their life that are causing them to have a bad relationship with food. And at the end of the day, it's the patient who has to make that change, and it's all about their behavior and their relationship. There's nothing that I can do with the data that I have unless that patient is going to change. And I can't even tell you how much difficulty it is to try and convince someone why it's important for them to eat an apple or to have a yogurt. They won't do that because it's too overwhelming for them. And I have a picture from a 200,000-foot level, and I'm dealing with someone who can't even manage to live day by day. And so that's the challenges that I'm faced with. And I just wanted to throw my experience out there because data is important, but at the end of the day, it's also about the relationship that that person has and how they're going to use it to make that change for themselves.
Go ahead.
I will just say we are staking our company on what you just said. Over the last 4 years, we have 100% shifted. We don't really pay attention to your clinical. Eliza doesn't. Our customers want us to, and we will when they tell us to, but when left to our own devices, what we have learned over those now 1 billion interactions with real people is when we say to someone, take care of your diabetes, go get a mammogram, get a colon cancer screening, very rarely does someone say they're not going to because they don't believe in it or they don't think it has value. What they say is, oh, I would love to, I can't. My husband just lost his job, I'm caring for an aging parent, I'm going through a divorce. And I'll give you a silly statistic. If you are a pilot in the Navy and you are going through a divorce, you are not allowed to fly. You're grounded. You're grounded, why? Because it's a closed ecosystem, and the military's learned over time that people who are going through a divorce are incredibly stressed out. This translates into bad health, and they crash planes, and they die, and this is very expensive, and so they've stopped doing it. Meanwhile, every single day, my company does about 1 million outreaches to people. We're not allowed to ask, you all right? You're going through a divorce? You caring for an aging parent? Financially stressed out? And so we launched a movement a couple years ago saying we think the biggest diseases in the US are not asthma, it's not diabetes, it's not CHF, it's being a caregiver. It's having financial stress, it's workplace stress, it's relationship stress. And we have to broaden the definition of health to include these life factors. I can also tell you that over the course of doing all this data, I can now tell you that people who are highly vulnerable, that's the term we use for folks who are dealing with a lot of stuff without a lot of resiliency, are 1.75 times as likely to have immunity issues, 2.6 times as likely to have diabetes, 2.9 times as likely to have back pain, 5 times as likely to have mental health. They're $4,000 more expensive, and they're 4 times as likely to be in the top 5%. So we did this research not because that's what motivated us, because that's what's finally getting our big customers to pay attention to ask about something besides your diabetes. And the last thing I'll say, which I think all of us should pay attention to, is one of the things that we hear back from individuals all the time is, people with diabetes especially, I feel like I have a dollar sign on my back. That's how they think the healthcare system interacts with them, right? Because we're like, how's your diabetes? God, I don't know, I'm so stressed out. Tell me about your diabetes. Well, I mean, I just went through a divorce. But your diabetes, come back to your diabetes. They're like, I don't give a fuck about my diabetes, to be quite honest. And I think until we develop empathy, and until we stop thinking that everybody out there is just stupid and not following directions, and if they just follow our stupid directions, they will be healthy, and recognize the reality of the situations that they're in, we're not going to bend the trends that to date we have not proven ourselves able to do.
And I'm going to put a pitch here for an awesome organization who was founded to deal with exactly this problem. If you haven't heard of Health Leads, Health Leads on Rebecca Roney's organization. You should know about it because their basic observation was the single biggest preventable disease in the US is poverty. And actually the immediate first order consequences of poverty, which is why, I don't have the money, I don't have the public transport, I'm not going to make the visit, all of the things that follow from it. And they're trying to hone on that particular part of the system. So go find out about them, give them money.
Do you have a question? Go ahead.
Hi, I'm Jeff Spilmer from the Product Innovation Department at Athena. So when you're aggregating health data on a large population of patients, there's potentially a lot of liability involved in deciding this patient is sick, this patient is not sick, this patient is someone who a clinician should be paying attention to when, no matter how smart a piece of software is, it doesn't necessarily have the clinical decision-making abilities of a physician. So what do you think the implications or liabilities of that are? And though this may be a dangerous question in a room full of entrepreneurs, do you think we need potentially more regulation on the industry in regards to software and mobile apps?
Yeah, so I'll start with taking on the question. So I think you're right, there will always be errors. At the end of the day, it's a probabilistic model, right? So there's confounding factors, there's various other factors. I think there's a few things that you have to be very clear about. So one is, we don't do any sort of diagnosis, right? So we're not saying this person has a Kvedar, or we're basically saying this is your triage list or prioritized list of people who are behaving in an unusual manner that corresponds to this condition. And the second is, if you look at the alternative, it's not that the alternative there's a clinical measure that we can tap into. The alternative is absolutely no data. Is like the next report comes in 3 months in. We have institutions on the system where their way of collecting data before using Videography was sending them a 70-question survey. These are chronic patients who are very expensive. They're costing at least a few $1,000s per month in the healthcare system, or more. And who fills out a 70-question survey? And so the compliance rates are horrible. They have absolutely no data. We've spoken to health plans where the way they do outreach for their nurse call centers, or care coordination centers, care management centers, was they use the data from the last year and they go through that list, right? And that says absolutely nothing about who needs help this week. So you're right, I think there is room for, there always will be noise, and you have to think of noise as you design the intervention, which is why I'm not a fan of actually sending an ambulance to the door. I think the interventions have to be extremely low cost. Could be something like sending them a text message, or sending their family member a text message, or some really low cost intervention, which is even if you're wrong, it's fine. But we're competing with absolutely no data. So I think that argument doesn't really count.
Yeah, just on the regulation piece too. I mean, I did a lot of work at Red Cross and saw them go through 510K compliance 50 times over with the FDA, and you change. There's no concept of agile iterative development with the FDA. You submit it once, pray to God, and it comes back rejected. You need to go back to the drawing board. So I think taking stuff like this and incorporating more modern, not dinosaur development concepts into them too, could help with a lot of that and actually help us get to a point where some of these devices could be making medical recommendations at some point.
Question?
Hi, I'm Olivia Walken, and I've been on the clinical side for many years as a nurse midwife and practiced in 4 different states with very high-risk patients. 2 of those states being the I have a little sugar states, and then 2 where English was not a first language. And then I've been on the HIT side, and now I'm on the obesity side. So I sort of have been around, and all of you address access on some level or another. When you look at these really high-risk populations, some of whom don't speak English, most of whom don't have any resources, many of them have kids with smartphones or other gadgets. How have you thought about engaging? Because without engagement, there is no data. And so I think we live in a bubble a lot of the times. We're sitting in this room and we're bubbled. So how do you engage this huge population that's pretty disenfranchised? I just want to say one thing, which is I find it rare that I have the privilege of sitting in a room and listening to five speakers, all of whom are incredible. So thank you.
Now you're after your compliment. I forgot your question.
We're so unused to having people say that.
Oh, I know. My comment on that really is, I wouldn't choose a connected health intervention for that population first. I'd choose a high touch intervention for that population with a lot of human contact. But there's so many other people who get all the human contact that don't need it. And that's really the way these solutions, I think, should be placed in the ecosystem is they can help us sort out the populations like you're describing. Quick example, we have had a lot of experience with Diabetes Connect, which allows us to offer diabetic patients, I mentioned it briefly, an opportunity to log their glucose and have it automatically uploaded. And guess what? Your provider suggests, tells, recommends that you check your sugar twice a day, and most people don't. And so this enables us to segment that population and say, wow, here's the group of people who aren't even testing, and go after them with a much higher touch intervention. The people that test twice a day all the time actually do quite well because they're adherent generally. So the tools allow us to segment, and then the segment you're talking about, I think, deserves high human touch as part of their intervention.
So I love your question. I think that's where the crux of the problem is. And so to give you an example, we're working with one of the largest hospital systems in one of the sugar states. They had, I believe, 18,000 cases of undiagnosed diabetes, of people just walking in, not realizing that they have diabetes. And this is where, by the way, the majority of the healthcare costs and things are coming from. It's not the people who have their Fitbits and they're running. It's people who barely watch what they eat. And what's interesting in that population is, they are using our platform. So smartphone penetration is really high. And in fact, turns out, even in certain sections of society where people don't have access to a lot of other things, the first thing they buy is a smartphone. And I've personally seen in our system, customer support, we have patients call in and sometimes they'll ask us questions like, I've never set up email on my smartphone. Or one of the questions, one of my favorites was, I have my email open on my computer. Do you think I can open it on my smartphone as well at the same time? And things like that, we wouldn't even imagine these are the sorts of questions that come up. We have people who speak Spanish, who don't speak English as their primary language. And the beauty of all of it is, for our system, it's all passive data. So as long as you install the app once, you don't have to do anything again. You may ask you, or your provider may ask you answer questions. It gives us training labels, helps us understand better. But I think for a lot of the sort of automated sensors where you don't have to act or do things different from the way you're doing, I think somebody mentioned the temperature sensor earlier and a few other examples, not some of those examples. I think that's where the opportunity is.
And if you want a sense about how important smartphones are for internet access and connectivity in the disadvantaged portions of the community, Pew's latest data came out yesterday. It's now 1 in 3 of people who do not have home broadband and a personal computer rely on their smartphone for internet. In the Hispanic community, it's 47%. In the Black community, it's over 50%. And amongst young people below the age of 29, it's 3 in every 4 who don't have fixed internet access depend on their smartphones. So we've reached a point where smartphones as the mechanism for internet access amongst the disadvantaged communities and minorities are the biggest single shift. And if you read the data, people will say, well, the rest of them don't think they're going to need it and they don't see the need. Actually, of those 30% we have now adopted, 90% of them, 2 iterations of the cycle ago, said they have no need for it.
I think we're not answering your question. My smartphone is not going to feed me. My smartphone is not going to get the heat back on. My smartphone is not going to take my mother who is slowly dying and I have to care for her every minute, and so I lost my job and I can't take her to the doctor. My smartphone's not taking her those places. And so with all due respect, with all of our beautiful, sexy apps, so what, right? I think for that population, I hope everyone in this room has read Hotspotters. I think that was the name of it, the article by Atul Gawande. Go read that and then ask yourself what your app is going to do for those people. And the truth is, eventually it should be able to, because actually you could do things that would begin to help. The number one most important thing to do for that population is to start by saying, this is hard. We understand. You're not alone. Let us see what help we can get you. Right? So I can't answer the rest of your question because when you read Hotspotters or you've been in the healthcare system actually delivering care as you have across the continuum, and the same comment to the woman who was a nutritionist, you know how deep-rooted and fundamental some of these problems are, and there's no one-size-fits-all, and there's no one-hit wonder. This is going to require a turning inside out of us to address that specific population and to approach them first as humans and not patients. And forget what stupid conditions they have and first figure out what's driving their behavior on a moment-to-moment basis and how can you try and help with empathy in that spot.
I have a somewhat tangential question. I know a lot of these programs are contingent on having a primary care physician or any sort of doctor. However, if you're dealing with, say, the younger side of the population, which might be early adopters and probably are making those stupid health decisions that will lead to chronic conditions, is there a way to seduce users to download the new sexy app and then get them to a doctor?
I don't think, I mean, as I laid out, the segmentation we use for the behavioral response to digital goods is the analogs who have never adopted, never really transitioned the world. And I agree. For them, my point was high-touch solutions, absolutely critical. That is changing. And one of the biggest changes is even amongst that group, the number of the remaining pure analogs is going down. Digital immigrants, everybody in this room basically over the age of about 30 who's actually, if you're in this, I presume you're a digital immigrant. Because we're the people who started out in the analog world and actually at some point during our adult life transition. And we have a very distinct set of behaviors which is different from the digital natives. Candidly, at the moment, digital natives are not our problem. If we look at this from the point of view, if you want to have impact, if you want to change outcomes in a meaningful, in a giant epidemiological sort of way, like it's actually older people, poorer people, those incentives. It's not the candidly the people in this room. And that's why I believe a liberal little bit of automation say it's a combination of automation and people. Right?
Yeah, and the only thing I would add to that is I don't think this is true for any of our work or companies in this section, but there are companies out there which are very heavily on engaging some of those populations. And IPR is an example. I think there are companies here like Impact and so on, which are autodocs and engaging their population. I think what would be really crazy if somebody like that decided to start a health plan which had all those people and somehow cut deals and somebody's going to do it, I hope. But I actually think there should be another health plan which is all like sensor-based and data-based. Somebody should do it.
I think another thing too, which we're not talking about that I hope we do all carry this forth, is, we can do a very good job. I can show you lots of statistics that we do a very good job getting people of all ages to engage. I'll give you two examples of younger ones. One is we told women that this is actually 40-year-old women, that their mammography machine really missed them. And that's why they should go. And then we took a company from the 25th percentile to the 90th percentile, because these are educated women. They know that they should get a mammogram. That's not why they're not getting it. They're just not prioritizing it. So the engagement mechanism was to appeal to a woman's need to please everybody. That's being grossly sexist, and I apologize, but in this particular case, it happened to work. We reached out to men, young men, 18 to 30, that we wanted to do something, and we sang them, beans are good for your heart. The more you eat, the more you help your heart. What do you think I was going to say? And this was the single most successful campaign that this organization had run because it was engaging. The problem with everything that we're talking about today is stickiness. And I would challenge this room. I had one of those Fitbit things for a while, and then I threw it away in a rage because I don't like the data it tells me. And I did a walking group for a little bit, and then I thought it was boring. And I tried gaming stuff, and then I quit, right? So we're fickle. 25% of health apps are downloaded once and never used. Downloaded, used once, never used again. 75% discontinued after 10 uses. So I think the question we have to ask ourselves is we have to remember that people are fickle. Their lives don't revolve around their health. How do you not just make an interesting app, an interesting product, an interesting game, but a game that keeps on morphing and changing to the extent that it will hold the attention of the fickle nature of the people in this room? Because I would challenge most of you are no longer doing whatever you did at some point a little bit ago.
So I'm kind of struck by the way you're arranged right now. From the House left, we have folks who seem to have objectives and incentives that improve outcomes, and at the House right, on the far side, the objective seems to be to increase the amount of money that physicians pulled in, and the incentives, of course, are highly correlated. In the middle, we have the man with the question mark.
In the middle, we have the man who thinks it's about money, and I hope that's come across, that they're actually, you've got to deal with both the intrinsic motivation, the desire to have a algorithm, that's why you go prefer to actually help people make better decisions about this.
Well,
And
thank you.
also
You're actually
recognize that
answering my question. You're anticipating my question, which is, how does this work? Who wins out of this?
Yeah, you've got to both need to be reconciled. Pure, much as we would wish it, pure altruism isn't a paid bill. But just worrying about the money is also going to lead to misdirect incentives. It is a nasty balancing act, which is why we put so much emphasis on understanding incentives. And incentives in this domain are different. We talk about incentives. We didn't use the term payoff. We didn't say follow the money. Right? The incentives and the rewards are very different, and you've got to think about the combination of things. Is it a satisfying criterion on the money for some people? You know, is it meeting max regrets for other people?
Go ahead. We have time for Anmol, if you want to respond, but we have time for about one or two more questions.
Yeah, I mean, I think long term, once the incentives are aligned across the system, the two are the same, right? What gives you better outcomes should also have the most amount of savings and the most amount of impact. I think that the challenge for companies like us is that transition in the system that's happening now. Is it going to be 2 years or is it going to be 15 years? Right? The EMR systems are really invented with diabetes, and it took about 15 years to become a real thing, and that happens for us. We're not going to exist, and that's I think the biggest challenge for companies like us.
So this might be jumping a little bit far ahead in the future, but it seems like a lot of these quantified patient projects involve one app that basically tracks maybe multiple metrics, but what makes one conclusion. And I'm wondering, how do we scale this up? Basically, how is this scalable? Because we have a hard enough time getting people to use one app reliably. How are we going to get someone to walk properly, check their blood glucose, sleep properly? How does that data get aggregated? How does it get analyzed? How does it get collected from the patient and viewed from the provider? Like, what sort of ecosystem exists or could be built that would actually allow this to happen?
So every startup in the space has a slide. Okay, I can guarantee you, I've seen lots of slide decks for all the 2x sensor companies for everything, which says we're going to combine data from all the sources and something on. And these guys are actually making it real, but all the way from Runkeeper to people like us, everybody has that slide. I think the challenge though is you've got to be, it has to be, for what we're discovering, it has to be condition specific. Right? It's not, there's no value in us for connecting any sensor data, but if you're doing something in CHF, then like Core Cardio and other companies like that are really your partners. If you're doing something that's in the context of diabetes, then Sugar Sync and Grupo and the companies in that space, IBG Star are really your partners. And so it has to be, what we're discovering is condition specific as a next year. But,
so, and my take on this is this central point about, I talked about being about the paradigmatic stage, about where you are in the evolution of that coordination. First of all, you don't build ecosystems. Ecosystems of a particular ecosystem like this. There's no single actor, the resources, the incentives, the motivation, or the skills to build this in a central way. And that ecosystem, so it's going to have to emerge. And to your point, in emerging, it's going to have to emerge in a way that reconciles the whole place. This I actually think is going to be, we think this is going to be the big problem. Understanding how you play in it and figure it out. From a sort of technical perspective, the biggest single and most important shift would be the move towards the cloud, move towards secure ways of federating APIs across services, which is the single biggest shift for those who have been following what's happening in the technical architecture, because that means that you can, in essence, with appropriate compliance mechanisms, mash stuff up. And if you can do that, then you may well be in a position to actually solve a variety of problems. It's not just happening in this domain, it's happening in a variety of other domains. One of the things actually led to us becoming more actively involved in it was those questions about how do you integrate data from multiple sources together.
And you would agree, because we had this discussion earlier, that in the end, we can have all these devices talking to each other and saying fabulous things, but if they're not influencing the way that real people make decisions on a daily basis, then it's just a party, nobody's going. So I think the question ultimately comes back to, how do you seduce people into having an interest in and sustainably, scalably making better decisions about their health, and that I think is not answered with technology. That's answered with some old-fashioned things like marketing and, you know, looking at big data and different perspectives in terms of how people tick and how they make decisions and how you meet them in those places.
Great. Before we close, I'd like to request one more round of applause for our amazing speakers. Really appreciate everything you guys have done. Thank you everyone for coming out, and have a wonderful night.